Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring cardiac surgery in elderly patients. This podcast is sponsored by Macquarie University Hospital, part of Macquarie University Health, a trailblazer in healthcare, education and research. Professor Michael Vallely is a leading cardiothoracic surgeon who has clinical and academic interest in minimising the invasiveness of cardiothoracic surgery and is a world authority on total arterial and aortic off-pump coronary artery bypass surgery. He also has interest in minimally invasive cardiac surgery, MICS, and Vinci robotic surgery, transcatheter, TAVI and Mitra-Clip cardiac surgery, thoracic aortic surgery, geriatric cardiac surgery, and hybrid procedures including the use of ECMO. Dr. Nargis Shaheen is a consultant geriatrician with the special interest in perioperative medicine working at Macquarie University Hospital and Concord Hospital. She's a member of the ANZCA Perioperative Care Working Group and is involved in perioperative medicine teaching. They join me now. With the increased prevalence of cardiovascular disease in the ageing population, how do you assess the suitability of elderly patients for complex cardiac procedures?
Very good question. Number one thing is I walk down the corridor with them, and if they can keep up with me, they're going to be pretty suitable. Hand grip is very important as well, and muscle bulk and muscle mass is really important as well. And ultimately, it comes down to whether you think that you can fix the problem, and fixing the problem in the elderly can, from an open heart surgical point of view, can be quite complex. But the vast majority of elderly patients, and elderly is defined as anyone over 60, really, so that goes from 60 through to 100. There's a mixed bag. You can have a very well 90-year-old, and you can have a very unwell 60-year-old, so you've got to be very careful on how you assess those. But ultimately, there's a lot of, I think, frailty and muscle mass and all those things are the most important things that I see when I look at them. And also the risk benefit. If you think that someone's declining and is very frail, they're not going to get the benefit out of a very large operation. So I would tend to steer them away from that. I mean, obviously, one of the advantages of working with Nargis and I view myself as a geriatric proceduralist, and Nargis is a geriatric physician, and we get a lot of benefit out of multidisciplinary approach to these elderly patients. And the vast majority of elderly patients that come through our hospital are seeking a non-open heart surgery solution through the transcatheter program, with the structural heart program. And ultimately, what's happened is that they get referred through looking for a transcatheter solution, and there is no solution, or their problem is much larger than a transcatheter or even multiple transcatheter procedures can supply. So this is how I've kind of evolved with this. I adopted transcatheter surgery in 2009, so I've been doing that for 16 years, and we've had a multidisciplinary business that's evolved into a very large business, and Macquarie is the busiest structural heart program in Australia, actually, for a fairly small bed-sized hospital. We do the most structural heart transcatheter procedures in the country, and that develops a whole network as well around complex open heart surgery. So you end up offering patients very complex surgical, cardiac reconstructions essentially, and we require a lot of input from Nargis from a geriatric point of view in the perioperative period, but also helps with decision making around whether it's the right thing to do for a patient as well. And to be honest with you, the vast majority of patients are assessed as very suitable for surgery, even though they may be perceived to being old. I've always viewed age as a number, and the biology of the patient's a lot more important. So if someone gets to 85 and they're in good physical health except for their cardiac problem, and you fix the cardiac problem, the chances are you'll get them to 95, which is a 12%, 15% increase in their life expectancy. So I think it's really, really important to keep that in mind when you're looking at the patients.
Elderly patients often present with frailty and multiple comorbidities. How do these factors influence surgical planning and post-operative care?
So my journey with these patients starts most often in the preoperative assessment clinic, and then also going through their journey with them in the post-operative period, discharge planning, and sometimes even post-discharge. As we all know, older people undergoing surgery, they face increased risk of adverse perioperative outcome, which is irreversible organ dysfunction, delirium, which can lead to rapid cognitive decline and loss of function. So therefore, in order to for these patients to benefit from operative outcomes, it's very important that we see them through the preoperative assessment and optimize them prior to surgery or just before the surgery in order to prevent adverse outcomes. So preparing the elderly patients for elective or even sometimes urgent surgeries, it includes applying the principles of holistic care, which is most often just possible with the comprehensive geriatric assessment. Now, the comprehensive geriatric assessment in outpatient setting is much more prolonged. However, sometimes in inpatient settings, we can still get to the comprehensive geriatric assessment, except with time limitation. The first and foremost for me is risk clarification and, identifying the compatibility of this potential upcoming procedure. It's important to understand, is this patient suitable for the surgery? And if we are offering them surgery, are they going to benefit from them? Are they too frail to get this surgery, or can we optimize them in order to improve their quality of life and symptoms to get through this surgery? The other thing to mention, as Michael said, these patients have already been not suitable for the minimally invasive procedure. So their only option is to go through the open heart surgery. And that's the only way to improve their quality of life. My other aim in perioperative setting would be to identify and anticipate the potential perioperative risks, aid in shared decision making with the patients and the surgeons, and also advocate the best proven practice for a lesser complicated perioperative journey. This includes also informing the patients and their carers about the potential adverse outcomes, which helps with once they understand the potential outcomes, they are accepting of the risk, but it also helps with the post-operative journey so that they are not surprised with those outcomes. It's also important while seeing these patients to inquire and understand what their wishes are. Some patients, they do prefer independence over longevity, while as others, for them, just, longevity might be more important. Understanding this, documenting and championing their cause is very important, and that's what we deal with oftentimes. We do also try to understand about their end of life wishes, how much do they want to continue to require all the interventions or treatments that are necessary and not necessary. A timely discussion with the stakeholder, Michael and other care providers, is also an important part and is proven to improve outcome. And the other thing that I do with the comprehensive geriatric assessment is that there's good evidence to show that preoperative optimization of health conditions, as well as, addressing frailty, reduces the post-operative complications. This is achieved by involving the multidisciplinary teams. For example, if a patient needs nutritional needs, involving a dietitian, getting a physiotherapist to see them early on if they have to wait for surgery for even for a few days or few weeks, helps with reduce the frailty and improve their strength and post-operative outcomes. Involving the pharmacists for any medication management. Often these people are on multiple medications. Polypharmacy is a big issue with these patients, and which can lead to delirium and other adverse outcomes after surgery. So involving the pharmacist and trying to have medication reconciliation is also part of the perioperative assessment. At Macquarie, we are very fortunate that we have a good understanding between the surgeons, the allied health, myself, and other teams to improve the perioperative outcomes. I think we worked together for many, many years now to improve the outcomes, and of course, most of the times the outcomes are good.
It's from my point of view, I think, very clear. We have to, elderly people, as you alluded to before, have complex other problems. And so we're very fastidious in the workup for the patients. So you actually go looking for common things. So the patients get CT angiograms from, the top of their head to down to their femoral arteries. We go looking for, splanchnic vessel occlusions. We are looking for carotid artery problems, and we're very aggressive with managing all of those things that can cause trouble. So, for example, in the coronary artery disease space, my area of interest is operating on a beating heart without touching the aorta, which prevents emboli going to the brain, so-called anaortic off-pump surgery. And probably 5% of those patients need a combined carotid endarterectomy at the same time. And Walter Mahabit's, one of our colleagues, is a vascular surgeon. We go looking for those lesions and do those together. We also look at renal problems are common in the elderly. We've got lots of patients with stage 3 kidney disease. And I must confess, in my entire career, we haven't had a single one of those patients end up on permanent dialysis, and that's across the public and the private sphere. How you manage a heart-lung machine, you run a heart-lung machine with much higher pressures to perfuse the organs. And also expectation. There's an expectation that cardiac surgery is routine these days. My response to the patients is, well, it's routine for me, but it's not routine for you. And then an 80-year-old having a triple valve operation, for example, you create expectations for them and for the family. And the number one is, as people get older, they get osteoporosis. And so that means that their sternums are soft and actually get less pain. But an elderly patient having open heart surgery has a lot less pain than a 40-year-old man, for example. It's got a lot of muscle bulk with strong, paraspinal rib ligaments and all those sort of things. And also you tell them they're going to be in intensive care for the best part of a week and on the ward for the best part of a week. So that's 2 weeks, sometimes up to 3 weeks. Particularly the patients having complex right heart surgery, they get a lot of fluid shift. And one of our other colleagues, Professor Martin Brown's very interested in management of the right heart. So we've got a lot of patients that come having right heart surgery. They may stay in our hospital for 2 or 3 weeks. And there's an expectation they would go to inpatient rehab after that. So the patients and the family come very prepared, knowing that they're going to be in the walls of a hospital, whether it's our hospital or a rehab hospital, for the best part of a month. And then it takes them, 3 to 6 months to get back on their feet. But the advantages of open heart surgery over some of the transcatheter procedures, it gives you the opportunity to fix all the problems. And I don't know that adding extra operations incrementally increases the risk once you've started on the journey of doing the single operation. Also, in the elderly patients, we do a lot of reoperative surgery that may have had an operation in their 40s or their 50s or their 60s, and they're coming for reoperative open heart surgery. And so they've been through that journey once before. So the patients are fully aware of what they're going to go through. And once again, often they bounced around looking for a less invasive option, or they've been, reach the extent of what medical therapy can offer them. So there's a lot of prehab involved as well. We've got to optimize their physical well-being, but also their medical issues, renal, neurology. And so that's kind of what I do. We have exhaustive workup, and so we know exactly what's going on inside the patients, and we fix all the things that we need to fix. And I think that gives everyone the best chance of the best outcome we can offer. We have had the same intensive care doctors that we've worked together now for more than 15 years. And so they know us and we know them. Same with our anaesthetists, they're the same. The scrub teams, the surgical teams, we've got a cardiac theatre 5 days a week. We've usually got 3 or 4 or sometimes up to 6 cardiac anaesthetists working in the building doing different things. We've got 2 cath labs running at all times. So it's a very busy cardiovascular procedural hospital. So there's always people around, and the institution's very used to managing complex patients. And we've got a fantastic imaging department with Macquarie Medical Imaging downstairs who can provide us with 24/7 information that we need for these patients, that goes along with the very busy neurosurgical department as well. So there's a disproportionate amount of pretty high-end surgery happening in what is a pretty small building, really. So it's a very easy place to work in that sense.
Macquarie University Hospital is known for its excellence in minimally invasive surgery. Can you tell us how innovations like robotic-assisted surgery have transformed the surgical approach for elderly patients?
The elderly patients who have a simple problem we can manage often with a catheter. one of the issues with minimally invasive surgery in the elderly is they have vascular disease in their legs. And when you do robotic surgery, you need to use a heart-lung machine through the vessels in the legs. But as long as the patient is free of those diseases and also needs an operation that's not extensive, then they can be suitable for robotic surgery. Robotic surgery is often applied to younger patients with single lesions like mitral disease or coronary disease. But often in the elderly, it's not as applicable because they get a catheter operation, like a transcatheter operation. But certainly Macquarie would be one of the busiest cardiothoracic, robotic and minimally invasive centres in the country. But once again, most patients in this elderly complex space are not actually suitable for minimally invasive surgery. And if they are, they would end up with a catheter rather than an operation. So it's slightly different. We do offer it as much as we can, but within the proviso, as I just said, a lot of them have got pretty bad peripheral vessels, and you end up causing trouble with what we call retrograde flow, so that a lot of emboli get pushed back into the circulation. Their stroke risk is higher, and also they have issues with their vessels as well. So a lot of them, when talking about the really elderly, people over 80, they've often got such a complex problem that it's best managed with an open operation. It's done efficiently and quickly.
Okay, and just on technologies, what emerging technologies or research do you believe will significantly impact the field of cardiac surgery for elderly patients?
I think that the transcatheter space is just going to get better and better. And I think that the reality is that the number of open surgical operations will decline. And so I think you'll find that open surgery will be reserved for infected prostheses, for really complex things that are just not addressable with a transcatheter. I think in a decade's time, with the amount of money that's going into the transcatheter space and the structural space. And as far as elderly patients go, I think what has happened over the years with cardiac surgery is that as technology from other specialties comes in and, looks after the pathology in these patients, that surgeons just end up doing higher and higher and higher risk patients and get better and better and better at it. I think there's a lot of patients we're doing now that no one would have even known when I was training, 25 years ago. They wouldn't have even been discussed for surgery. So what we're doing now is like in 10 years' time, I think we'll be doing as the population ages. And also there will be a role for surgeons to remove, there'll be transcatheter devices that have worn out or failed and they're not suitable for more transcatheter devices. So there'll be a whole subspecialty skill set that's required for cardiac surgeons, which is removing these devices that have been in them for 10 or 15 years and then doing quite complex operations to reconstruct the heart with the removal of these prostheses. So I think basically what will happen is that we'll be doing less surgery, but it'll be a lot more difficult, a lot more complex as technology, removes the need for more traditional open heart surgery. We'll just be left with really complex stuff, and that'll be a challenge. We're up for it.
Okay, next question is for you, Nargis. Given the multifaceted health challenges elderly patients face, how do you approach the comprehensive assessment and management of these patients?
So by trying to see them as early as possible, understanding their needs, trying to complete the comprehensive geriatric assessment, which involves all system management, review of all the system, review of all the organ dysfunction, complex underlying comorbidities. It also involves frailty and the potential reversible causes of frailty. So approaching these patients in this way helps us trying to not only, first of all, understand how best to manage these patients, but also try to optimize them prior to surgery. Involving the multidisciplinary teams very, very early on, there's good evidence that improving nutrition and improving their physical ability does improve the outcomes. We do have fortunate enough that we have all the multidisciplinary teams at Macquarie, which we involve early on and try to get the patient optimized within the time limitations we have in order to proceed for the surgeries. And again, discussing with if there's any, as Michael mentioned, any need for involving the other teams, like quite often renal team or any other potential medical teams or surgical teams, we do try to tend to get them early on involved, and that's part of my assessment as well.
I think the next question, I think you've more or less answered, but if there's something else to add, how does the multidisciplinary team at Macquarie University Hospital collaborate to optimise outcomes for elderly cardiac surgery patients?
We are very fortunate that we have a good CNC who has been there for a very long time and understands the need of these patients. We collaborate closely with each other, timely communication, trying to inform the relevant teams that are needed to achieve the best possible outcomes for these patients. And we're very, as I mentioned, we do have all the allied health teams available at Macquarie University Hospital. For a small hospital, the resources are quite good, and we involve them frequently, and we not at any time have I felt that we are lacking any resources that are available in other public hospitals. We are equally fortunate to have them at Macquarie.
Yeah, I'd even go further and say that we're a lot more resource than the public hospitals. Macquarie's, we've got a consulting floor where cardiac surgeons, cardiologists, respiratory and vascular all consult out of. So in the one corridor, we all work together. And so the patients will come and they can see pretty much everyone. We have a fortnightly structural heart planning meeting, which we can discuss up to 20 patients at a time, and all of the proceduralists, non-proceduralists, imaging. And also at those meetings, we can put up whatever patients you want to discuss, and then we can have an ad hoc multidisciplinary team meeting at any time we were needed, because we all work together and have done for so long. And the way it works is a lot of quaternary referrals. So a lot of our referrals are come from other places where they think it's a little bit difficult, and we can provide a better service, whether that be medical or surgical level. So we're very, very used to all working together and working side by side. And because a lot of us spend most of our week at Macquarie and have very little commitments elsewhere, we're always working with each other. So it's very, very easy. And as Nargis said, we rely very heavily on our CNCs, both the surgical and the medical CNCs. And the corporate memory there is extraordinary, and the running of the patients makes it very, very easy. So, and we're also very used to seeking each other's opinions before going into something, so everyone's aligned, and with the families as well, to make sure that everyone knows exactly where we're heading and what the expected outcome is, and those sort of things. It makes it a very easy place to work, actually. And we're, as I said, I think we're in many ways more resourced than the public sector because of the reduced barriers that are in private hospitals. To be honest with you, there's a whole lot of bureaucracy, unfortunately, in public hospitals that makes it quite difficult to actually get through to the end game, which is patient outcomes. So I think Macquarie, as an academic, as the first, possibly only academic private hospital in the country that's actually co-located on a university campus, is very much an academic, patient-focused, ethos, but then you have the benefits of the efficiencies that a private system gives you, which is remarkable. So I find that I can be more comfortable doing the complex, difficult work at Macquarie than I can in any other place that I work. It's fantastic.
And I agree to that, because the collegiality between all the specialists, the allied health team, the nursing staff is fantastic at Macquarie, and I enjoy working because of the culture that we have at Macquarie. It makes patients' journey so much better and much easier to work with.
What recent advancements in post-operative care have been implemented at Macquarie University Hospital to enhance recovery and quality of life for elderly patients undergoing cardiac surgery?
I started using a fancy new sternal reconstruction system with peristernal plates, and that's made a massive difference to post-operative pain and mobility in the elderly, and that's been wonderful. Other than that, I think we've optimized most of our things over the course of I'm not sure we've got some better supportive vests and things post-operative and those sort of things, but I'm not sure there's been any radical advancements, to be honest with you. because ultimately I think we're practicing at the pretty top of the game. I was fortunate over the last few years to spend some time working at a pretty senior level or professorial level in a couple of American units, and I think that a lot of what we do at Macquarie exceeded those places that I was working, which was good and reinforced that we were doing the right thing. So I think we offer a very comprehensive. We've got brand new heart-lung machines. We're often doing things in our operating theatres that are the first in Australia. One of the head of anaesthesia is also the head of the Medical Perfusion Society of Australia. So we're very at the front of heart-lung machine technology. As I said, we avoid the heart-lung machine if we can in the elderly. We know that's better, so our coronaries are done that way. So I think that there's been nothing radically different that's happened in the last little while, except that we're always on the lookout for the latest thing, and we'll evaluate that, and then off we go. I think we try and practice at the forefront as much as we can.
Although with with improved technology and best surgical outcomes, our length of stay in intensive care unit for the cardiothoracic patients has decreased. We become much more comfortable with the trained nursing staff and allied health to bring them much earlier to the ward, which reduces the risk of delirium and get them to mobilize much earlier, and that has also improved reduced the length of stay and improved outcomes for the patients.
MQ Health is a medical precinct. How does the integration of on-site services such as medical imaging, pathology, physiotherapy and pharmacy, as well as access to other specialists, enhance the care you provide?
Oh, it makes it unbelievably easy to practice. I mean, it's so straightforward. It's not funny. I'm in the pathology collections opposite my rooms. You walk across a bridge, probably 50-metre walk to the cath lab. You walk across and go downstairs, and you're in the medical imaging. You're downstairs in the intensive care. It's a very, very compact little area that we work in with enormous capacity to do. We've got, I think there's 12 or 13 operating theatres on the main floor, and there's another 4 upstairs in the orthopaedic precinct. And the building is tapped so that we can build more things. It's already ready to go for expansion, so there's no problem in expanding. And it's very large amount of procedural space. We have enormous capacity to do things. So whether it be imaging, interventional radiology, open surgery, and the cath labs, we've been in the process of looking at a third cath lab, which is more than most of the large teaching public hospitals in Sydney. Some are down to 1 cath lab. So it makes life so easy. From our point of view, it's the easiest place I work. You park under the building, you're there all day. Everyone. We're talking about this offline before, but the Macquarie's got the same people in the cafes, the same security guards that I've been there from the beginning. So there's a huge consistency across from our catering staff and security staff all the way through to, senior executives and what have you. So it's a very, very stable place to work. And so if you need something, you can pick up the phone and the people personally and get things done very, very easily. So I find there's the inertia is just not there. There's a lot of inertia in other parts of the health system, but Macquarie is very straightforward to getting things done. So yeah, it's an incredible place to work from our point of view.
Nargis, would you like to add to that?
I totally agree with what Michael said. And it's also just to add on that any procedures or anything that we need, even after hours, if we need any medical imaging or intervention, it is possible because we know each other and we are always ready to see the patients and improve the outcomes without waiting or delaying any part of the necessary treatment for the patients, because of the easy availability of all the resources.
When I was in my second or third to last year of training, so 2004, 2005, my 87-year-old grandmother had aortic stenosis, and the cardiologist, and she was living in northern New South Wales, and said she's too old. And I said, no, she's not. So I rang her GP, who I actually was at university with, but didn't know very well. And she said, well, she's too old. And I said, I wanted to go for this particular surgeon in Brisbane. And she said, oh, you do know we've got local surgeons? I said, yes, I do know that, but she's elderly and she needs to go to this person. anyway, she went off and had an aortic valve replacement and coronary artery bypass grafts, and she was in heart failure and stuck in hospital, and she would have died within the year. And then she went on to live to the ripe old age of 94, so she got another 7 years and lived very, very well right up until the end, and died very peacefully in her sleep. And she actually had become very frail at 94, so she was at the end of her, biological life. And her GP was very generous, and she said, "Look, it's interesting. You're right. She should have had surgery, and we look at the age, and the age is a number." And actually, a year or two afterwards, we actually wrote a paper with my research group, and we said, there's a paper on geriatric cardiac surgery, and the title was "Geriatric Cardiac Surgery: Chronology versus Biology," and the biology is way more important than the chronology. And people age at different rates. People that look after themselves, you've got these incredibly fit 85-year-olds, and you've got these terribly unwell 55-year-olds. And when I worked in the Midwest in the United States, I had 45-year-olds that were way sicker than the 85-year-olds that we're operating on. I mean, the chronic disease burden and the obesity and the lack of primary healthcare. The hospital healthcare in the United States is very, very good, but they lack primary care and access to drugs and other things. So bodies ravaged by diabetes, renal failure, and amputations in their 40s, terrible. So they're a lot more unwell. So for 45-year-olds, way thicker than these patients that we're looking at. So I think the reality is that it's really, really important to at least give the person a chance to be seen by people who are used to seeing people in this complexity, who are this unwell. And you might have someone who's terribly short of breath. If they're terribly short of breath, they've got a correctable cardiac condition that we can correct either with stents or bypasses or transcatheter valve or open surgery. And so what I would and even if the GP wants to pick up the phone and give us a call, we're very happy to take phone calls. And getting into CS is pretty straightforward. We have very streamlined clinics we can see people, and I think at least let us say no, as opposed to feeling the pressure to say no yourself, or say, "Oh no, you're too old." And often patients will come and they're very a little bit apprehensive, and they're a little bit pessimistic, and then you see them at 6 weeks post-operative and their whole life has changed. Correcting cardiac disease is very satisfying from our point of view because it's very objective. 99% of the time, 98% of the time, it goes very, very well, and people go on to live. As I said, my grandmother, it's an anecdote, but it's an important anecdote. It sat with me for my entire career, is that you should give these people the opportunity to have access to this technology. And the technology changes all the time. We do a lot of first in mans. We get a lot of access to devices that may not be available through the TGA yet, because Australia lags a little bit on the regulatory, but because of our access to our international network, we can get access to some pretty new technology, and we're very, very used to delivering new technology to patients as well. So in some ways, it's easier to get treated at Macquarie than it is through the university public hospital sector.
Chronological age should not be taken into consideration. It's the frailty. As mentioned, there are good 85, 90-year-olds who are still suitable for interventions, yet there might be a 65-year-old with multiple comorbidities, very frail, who scores about 6 to 7 on the clinical frailty score, who might not be suitable, yet they are still referred to us. So age should not be a barrier. As I agree with Michael, they should be referred and then seen by the relevant teams or identified whether they would benefit from the intervention.
The other thing too is we have the non-procedural physicians. There's several. I mean, as I mentioned Martin Brown before, but even overwhelmingly, we're so used to really sick people with lots of complex problems that even having their medications, as Nargis mentioned, it's not just the pharmacy, it's actually being on the right medications for the right problem. And this doesn't happen often. Often patients come with a diagnosis that they've been given 15 years ago that's actually incorrect. And so we actually get to the bottom of the problem and actually can correct them from a medical point of view as well. And that can be a game changer. It doesn't happen very often, but it does happen. And I think sometimes the benefits of all of us are in the space of looking after very sick people all the time, so we're used to it. Whereas I think, GPs see everyone at every stage of their life with all the different complexities, and they may only have one patient who has this particular problem, but we might see 20 in a week. So I think that's the number one thing, is if it's becoming a little bit baffling, or they're not getting the answers that they want from their usual network of specialists, it's not a bad idea. We get a lot of second, sometimes even third opinions that can be, and there can be a drastic change in the outcome for the patient. So, and it's also really important to understand that the patients are being referred for a consultation opinion. So don't feel that if we say no to a procedure, that anyone's made a mistake. So I think that they're coming for an opinion, and I certainly don't operate on everyone that I see, but I think it's really important that we're given the opportunity to see them and help them in whatever capacity that is.
Thank you to my special guests, Professor Vallely and Dr. Shaheen. This podcast is sponsored by Macquarie University Hospital, part of Macquarie University Health, a trailblazer in healthcare education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.